تحياتنا. Hi everyone. For sake of time and because of a flight connection with Van Bardeleben, we will introduce him. You've known him yesterday, and he will talk about the toughest talk of today, TAVI in aortic valve regurgitation. I'll do the objectives after the talk of Van Bardeleben.
Hello, everybody. Thank you very much for inviting me, and it's a great pleasure to talk about the next frontier in TAVR. And TAVR worldwide is well accepted. We're in the millions of implantations, and it's a life-saving entity with a number needed to treat of about 3 or 4. And we'll see that the change that we've seen in TAVR for aortic stenosis may be ongoing in a slightly younger population of aortic regurgitation with tricuspid valve disease so far. These are my conflicts. TAVR for aortic valve regurgitation, or as we say in Europe, TAVI, is an entity that has shown many guideline changes in the past 15 years, and it will also influence next guidelines, both in aortic stenosis, as you see here. These are the most probable guideline situations that will stay there marked in green. But the age limit, the situation of low-risk patients, the situation of elderly and younger patients are changing in the next guidelines, which will be in 2025. And why is this the case? We should have an appreciation that the 5-year mortality rate in TAVR dropped significantly. 3-year, 2-year mortalities, 30-day mortalities, and stroke volumes, actually stroke situations, major stroke, cerebral complications, actually are down compared to surgery by 50 to 60% in the latest trials, like the DEDICATE trial, which was randomized with 1,400 patients. If we look into TAVR or SAVR in the lifetime management, this is, of course, data from aortic stenosis first. We see that depending on the age, Ross procedures, SAVR, but also combinations of TAVR, TAVR in TAVR, and SAVR in TAVR ping-pong strategies are being used currently, and this will be an ongoing issue. There are new valve generations in 2024, and we know that we have a number of devices which gained a very high performance. And this improves coronary access, this improves anatomic alignment like in surgery, this improves lifetime management, and to have less and less aortic regurgitation or PVL, and a significant reduction also in the pacemaker rate. Patient selection is a dynamic change. If we compare the advantages of TAVR versus SAVR, we see that currently in all guidelines and publications, aortic regurgitation is just mentioned as a concomitant disease, as you see here with moderate or severe AR, which currently favors surgical approaches. But TAVR is a 20-year-old and long journey of a transformative evolution. And if you just look at the right, take a notion of 2002, the first TAVR, and 2024, you see the DEDICATE trial, you see the TCW trial from Europe, the NOTION trial for lifetime management and longevity, durability of the device, but you also see the US ALIGN AR trial with a brand new device that was not anymore looking in aortic stenosis, but was looking dedicated into aortic regurgitation. So aortic stenosis and AR are completely different pathologies. It is rare in comparison to aortic stenosis, but like tricuspid disease, it's an under-recognized problem and valve problem. There is a volume overload, there is no pressure overload, and the problem for conventional TAVR prostheses is that there is nearly no calcification, as you nicely see in the CT, and it's often also coupled with aortic root disease and ascending aortic disease. So there may be aneurysm or ectasis of the ascending aorta with a risk of a pop-out or pop-in of the valve into the ventricle or into the vasculature. And up to now, it is often a totally surgical therapy. So if we look into the guidelines of the ESC and AHA and ACC, you see that TAVR may be considered in very experienced centers for selected patients with aortic regurgitation and ineligible for SAVR. And the American guidelines go further. It's challenging because of the dilatation of the aortic annulus, aortic root, and many patients a lack of sufficient leaflet calcification. So the risks of TAVR for treatment of AR include transcatheter migration and a very significant paravalvular leak. TAVR is rarely feasible, and then only in carefully selected centers and patients with severe AR and heart failure who have a prohibitive surgical risk. This is the guidelines of 2021. What about the differences in aortic regurgitation between Europe and the United States? And you see here green signs, recommendation class 1, but you also see warning signs in red here and discontinuities. And you see that AVR with moderate AR, other surgery, etc., is a 2A indication actually to go to surgery. What about the diagnostics? Aortic valve regurgitation is more difficult, but it's very important that the guidelines definitely say that inability to do surgery and medical therapy should not be used as a temporizing measure to delay the referral for surgery or for intervention, so for treatment. The valve assessment key points is, and this is very good, TTE is the first-line imaging tool to actually assess valvular regurgitation. TOE is with a low threshold advocated when TTE is non-diagnostic, and 3D offers more insights into the pathophysiology and anatomy. And I'll quickly go over this, what we're looking for. It's valve morphology, annulus diameter, vena contracta width, cardiovascular regurgent jet, and a flow reversal in the aorta. Very important points. There are additional possibilities to look at this. This is MRI, for instance, and it's also the volume situation of the ventricle, as you can see here. And these are examples of dilatations of the ventricle caused by aortic valve regurgitation, which may also cause ventricular fibrosis. Magnetic resonance imaging, though a secondary tool, is better in AR. It is not better in mitral regurgitation, as you see here in the comparison of the areas under the curve, and you see CMR is given here in blue. So aortic regurgitation, if you are in control, often TTE is the best entity, but MRI should be taken into account if available. There are new goals actually for younger patients and AR patients, and this is safety. We have the problem of congenital bicuspid anatomy, which makes the valve design, the TAVR design, more challenging. And we're also looking into anatomic correct positions to access the coronaries over lifetime situations. There are cofactors like bicuspid aortic pathologies, low coronary ostia that I'll show you in samples, and small root. And there were trials in the past with conventional devices. And you see here that these conventional devices had a far worse outcome compared to dedicated devices in the past. So what about the future? What about the situation now? And this is, for instance, J-valve that I will mention, and the JenaValve trilogy technology, which is a technology that was already developed 10 years ago. It was first transapical and had to be revamped to a transfemoral access. The importance is you're always neocommissural aligned. It is an optimal device for coronary access, even in a valve-in-valve situation, as I will show you. But of course, availability is limited, cost is higher, and there is no long-term experience. So what about the first European registry data? And this is from 6 centers, including our center. 58 patients. We had 100% transfemoral access, and you can see that the reduction in AR was spectacular, and also technical success was about 97%. Then there's the ALIGN AR trial in the US, as you can see here, also with a very, very favorable situation, but one caveat, and this is a much higher pacemaker rate than what we used in aortic stenosis. It is around 20 to 24%. And this is because of the missing calcification. So I'll just give you some case examples here. This is a JenaValve, which was put not in a native anatomy, but in a Medtronic freestyle prosthesis with only 4 millimeter coronary height. So very, very difficult, Walid, to do this with a normal TAVR device. But because these feelers take the tissue levels and the leaflets down, even of a prosthesis, it was possible to clear the coronaries at a height of 4 millimeters with a very favorable situation. Second patient, 82 years old, heart failure, ejection fraction 35%, Euroscore 8, prohibitive situation, as you can see here. So we did an intervention, and you see here that also his access was very, very difficult for the large sheath of 18 French. So what we did was to puncture the patient transaxillary, and it was also possible to implant this valve from a transaxillary percutaneous approach. And you can see nicely here the feelers, the situation of the coronaries in the leaflets, and also the final result that you see here with a trace regurgitation, also in echocardiography, as you can see here, perfect result in this patient with a transaxillary access, and also a very nice situation of the vasculature after access, no gradients. So already my take-home messages for this new future device: aortic valve regurgitation is a relevant valvular heart disease, also in patients above 75 years. Guidelines currently are agnostic to direct transcatheter options. This will change next year. And new dedicated devices like the JenaValve Trilogy, that is already CE marked in Europe, the J-Valve, are upcoming, and surgery is, of course, the standard therapy of choice with congenital bicuspid aortic pathologies in younger patients, but TAVR will become the first-line alternative for elderly and higher-risk patients. So the new guidelines will change, and you will have the decisions of a multidisciplinary heart team. Thank you very much for your kind attention from our center.
Thank you, Stefan, for this nice talk. Actually, as you said, we are crossing the boundary, and we are targeting more and more aortic regurg. Do you think with what we get from this trial, we can already discuss a changement of the guidelines, or surgery will be and will remain the gold standard even for high-risk patients? You know, I'm a surgeon, and we are doing well with the David and Jakub procedure, so the results are very good and are actually durable in the time. So how are you seeing this?
I think it's early to say, but I think it needs a mentioning in the guidelines. So we're at the level of the European guidelines, like transcatheter therapies about 4 years ago, 5 years ago. There was no data on transcatheter tricuspid valve interventions, but it was mentioned as a level of evidence C situation with a 2B indication. So I think there is a medical need. We know that the technical success is by far surpassing. We have hundreds of patients. We'll now have a registry with more than 300 patients. So I don't think it's ready for a prime time recommendation, but to be mentioned as an alternative after careful exclusion of surgery, I think this is the right time to do this. And I would be very cautious, of course. I said we need long-term data, but it's a very favorable design, and we have 10 years of knowledge with this device. So durability in aortic stenosis, it's a device that can do aortic stenosis and regurgitation. So there is long-term data already out there.
Thank you very much, Stefan. Thank you for your involvement in the Tunisian meeting. Great talks. I think you have to leave for the airport. Thank you very much, my friend. See you next week. So a question to our Tunisian panelists. How we are managing aortic regurgitation in Tunisia now? Is it with David or Jakub Reaper, or just bioprothesis SAVR?
Just one remark, because I have one of these patients who are in this registry. Now we have a follow-up of 2 years or 3 years now. He was last to Thomas Modine to be operated because of very high risk, and he put TAVI valve, and she's now very good. Ejection fraction is ameliorated, but now I think we have a place to be to implant such patient, because not only for the cardiovascular risk, but the accessibility to surgery. I said yesterday that, and I repeat it now. I think we have a lot of patients who can be treated or in registry to be in trials.
I agree with Dr. Morali. In fact, in Tunisia, all the aortic regurgitation were operated by a cardiovascular surgeon. But I think, in fact, we don't have an experience with the TAVI in aortic regurgitation. You have only for aortic stenosis. But I think that we need it especially in patients with aortic regurgitation and with severe left ventricle dysfunction. Because in this situation, the surgeon doesn't accept to operate such patients. So I think it's a good indication in this situation. Salma?
Thank you again for your excellent presentation. I have just a question. I think that interventional treatment will be the future. But in aortic regurgitation, we also know that is not only the valve, but also the aorta. And I think in the technology and the development, it isn't the same thing. It isn't TAVR, a sample TAVR. Because I think that also the aorta could be could evolve, yes.
Absolutely, but there are cases with restriction after radiation, after also infection, etc. And I showed you a patient with 82 years with a normal aorta and aortic regurgitation. So there is also leaflet disease. So we shouldn't say that everybody has aortic root disease. This is not the case. So we have hundreds and thousands of patients that qualify also for such a device. And as was already mentioned, LV ejection fraction below 35% is a very good indication for this valve because the procedure is 20 minutes, 25 minutes. There is no standstill. It's just a rapid, it's not a rapid pacing, it's a fast pacing only. We do nothing more than 120 beats per minute during the implantation. This is an extremely nice situation, and the implant time after you have the feelers in the leaflets is about 2 seconds. The release of the valve is 2 seconds. So it's absolute hemodynamic stability. And the patients, actually, we just treated a patient from New York. Her NT-proBNP fell by 80% in just 3 days. You cannot imagine. She had aortic regurgitation untreated for about 4 years. She had more than 6,000 NT-proBNP, and it came down to less than 2,000 in just 3 days. So this is an extremely important thing to recognize. And once you have fibrosis in aortic regurgitation patients with bad LV function, they do rarely recover. You have to treat early enough to do this.
Is there a type of TAVI that's recommended to prosthesis? Type of prosthesis?
Yeah, there are two types actually. They're still in trials, but one is CE-mark, as I mentioned, the inner valve, and there's J-valve as a prosthesis that is possible, which has larger sizes, also human implants. So this is the future. This is upcoming. But in Germany, we have treated so far around 400, 500 patients with this device in pure aortic regurgitation.
Only characteristic is the possibility of to be largest, or there is other characteristic to search? The aortic size.
Well, aortic size, it's like the guidelines. Of course, if you have to treat and the patient is operable and you have a 5 centimeter or 5.5 centimeter aortic root or ascending aorta, you go for surgery. Unlike if the patient, if the surgeon says, I will not operate on this patient, then you just treat the valve. And also the progression is often halted if you treat the valve, actually, because of the eccentric jets.
So, thank you, Stefan, for the nice discussion. I think Salam have to present one slide. Okay, one slide about learning objectives, and we'll move to the lab in the box after.
I think the session is already open. On behalf of the Tunisian Society of Cardiology and Cardiovascular Surgery, and on behalf of all my colleagues, thanks a lot for the moderators and panelists of this session, Professor Granada, President of TCT, who did a long trip from US to be here. Professor von Bardeleben, he did his talk from Germany and Professor Walid from Canada, who are gracefully spending a full 3 days in our meeting that many of us did not afford. Should thank Professor Mourali and Professor El Abid, past presidents of our society and head of 2 certified departments for TAVI implantation in Tunisia, and active investigator in our national registry, TAVI.tn. We have as speakers to answer these raised questions. TAVI nowadays is a safe current procedure shifting towards lower risk patients for surgery. Challenging cases that used to be contraindication are more and more performed: bicuspid aortic valve, small annulus, aortic regurgitation, as Professor von Bardoben mentioned, coronary management before and after TAVI implantation. Implanting TAVI in younger patients raises the issue of durability and how to manage valvular stenosis. We have as speakers to answer these raised questions Walid Zoueri, Professor Slim Boudish, Tariq Allouz, von Bardoben, and Professor Granada. This is a practical session, and you have probably the best in the world in this room, few meters far from you. It is not unusual in a medical meeting, it's not usual in a medical meeting, but I invite you to please applaud these moderators coming from far to be here. ماذا بكم تصفقوا لهم يا جماعة بالله. And Q&A interaction is the key of session success. So please keep tuned. Dr. Zoueri, he will make his talk.
So very happy to introduce Dr. Walid Zoueri, a friend of mine coming from Lyon in France. He's will presenting a live in the box for treatment of bicuspid aortic valve with a balloon expandable platform.
So good morning, everyone. Thank you for the invitation. I'm really pleased to be here and to share with you this live in the box about a TAVI in bicuspid aortic valve. So to start, the clinical case, a 73-year-old patient followed for a bicuspid aortic valve, waiting for a renal surgery, symptomatic stage 3. First echographic data shows no LV dilatation, significant aortic regurgitation, aortic stenosis with mean gradient at 38, DVI 0.26, and pulmonary pressure at 42. No coronary artery disease, and a low-risk patient, so he was referred to our center to discuss about treatment of his aortic valve disease. So the first CT analysis, the first analysis of the CT scan shows good femoral access and aortotortuosity, which complete the symptoms of bicuspid aortic valve. When you look at the valve, here is a bicuspid aortic valve type 1 with a calcified raphe between non-coronary and right coronary cusp. At the right side, you can see that there is no dilatation of aortic root. So the heart team discussion was between TAVI and evidently with versus surgery. And TVT and STS registries shows that there are comparable results between TAVI and SAVR in terms of mortality and stroke. But we have to be careful because in bicuspid aortic valve selection patients, it's a population which was selected, and we don't know what were the criteria of selection. The phenotype of bicuspid aortic valve directly impacts midterm prognosis in TAVI. Indeed, huge calcifications are associated with worse prognosis. The phenotype of bicuspid aortic valve does not impact prognosis in surgery. That's the huge differences. So when you have a huge calcification of the raphe and excess leaflet calcification, 3 years mortality is really high. So in our patient here, we have a calcified raphe with no excess leaflet calcification, so he's in the middle risk of mortality at 3 years. Here, the virtual basal ring show that minimal mat diameter is 23 millimeters and maximal diameter 30 millimeters, and not huge ring calcification only on posterior in front of the mitral valve, so we can expect immediate and mid-term results, good results. So the heart team decision was TAVI. He was waiting for renal surgery. We have a high probability of successful. Redo TAVI also possible with no risk of sinus sequestration and coronary obstruction and also coronary access, but we will see this later. So the planification of the procedure was first the sizing. We are also going to discuss about the interest of cerebral protection and to talk about the optimal fluoroscopic view and depth implantation. So we are going to exchange about 4 methods for the sizing of bicuspid aortic valve. First, Bavard method. We have to check at annular and supraannular measurements at 4 millimeters, and we have to measure the intercommissural diameter and the perimeter derived by diameter. Here, in our cases, the annulus was measured at 28.8 millimeters, and here it's a tapered anatomy. It means that the intercommissural diameter is smallest than the annulus, and the intercommissural diameter is measured at 26.7, and the perimeter derived diameter at 26.7 also. The second method is the circle method. We need to draw a circle and anticipate interaction between THV ceiling and aortic root structures. So we draw a circle at the virtual basal ring 3, 6, 9, 10, 12, 15 millimeters. So if we draw here a 29 millimeter circle at the virtual basal ring at 0, we see the constraints between the valve and the virtual basal ring. We can see that at 2 millimeters, the valve seems to be a little bit big, and you have to check at 6 millimeters because the draw is next to the raphe, but I think that the valve will be a little bit pushed by the calcification of the raphe. So now with a 26 millimeter at 0, it seems to be a little bit small, but upper at 2 millimeters, it seems to be less injury with this part of the root. And at 6 millimeter, we can see that there is less left sinus sequestration. Another method is the Lyra plane. The Lyra plane was defined at the level of the raphe maximum protrusion, and at this plane we have to draw the perimeter, and here it was at 81 millimeters, which is a diameter about 25.8 millimeter. The last method is Casper method. This Casper is based on calcium volume, raphe length, and calcification. Here in this case, we have calcium volume upper than 300, a length of the raphe under than 50% of the annulus, and the raphe is huge calcified, so we have to use to undersize the TAVI devices minus 1.5 millimeters. So in this case, we decided to use a balloon expandable device with SAPIEN 3 to reduce the risk of PVL. We remember that we have posterior ring calcification in front of the mitral valve. We want to reduce the risk of pacemaker. The Redo TAVI is feasible and easiest with the SAPIEN 3, and in our TAVI center, easy to use. So what about the decision of the sizing? with the Bavard method, we have a tapered configuration, so we have to choose the smallest, and intercommissural diameter is 26.7 millimeters. With the circle method, 26 millimeters, seems to be better with less injury. Lyra is used for auto-expandable device, and the Casper 27.3 millimeters. So we decided to use a Sapien 3 for 26 millimeter plus 2 cc during the implantation. So discussing the cerebral protection, we know that the TORCH registry shows that there is greater number of lesions and larger lesions when we perform TAVI in bicuspid aortic valve. This randomized trial doesn't demonstrate interest of systematic neuroprotection for TAVI procedure, also for bicuspid aortic valve. But this retrospective cohort study with the NIST database with only bicuspid aortic valve seems to reveal a benefit to have a cerebral protection during TAVI procedure in this patient in terms of stroke and death and stroke. So we're going to start our live inbox. We have a left radial access for the aortography, and you can see that we have an aortic regurgitation, stage 3. We have a calcification of the valve, and also we are at the right side of the pigtail. We have the raphe. In this incidence, left femoral access was chosen because of anatomy consideration. We perform pre-closing with only one pro-style Abbott. And you remember that we had tortuosity in aorta, thoracic, so we put a stiff guide wire and after the E-sheet Edwards. We decided to use a cerebral protection because he was a young patient. We used the Sentinel device. First of all, we performed an aortography of the aortic arch to identify the vessels. The valve was crossed with a G-wire with AL1 catheter. In this catheter, we would use a Safari S wire. We decided to perform a 25 millimeter predilatation balloon and to perform also an angiography here. It's better to feel the constraints with aortic root, not really for the sizing. And after the implantation of the Sapien 3. We will discuss just after the positioning of the valve and depth implantation. We are here in the plane of the annulus, perpendicular to the plane of the annulus, and we are looking for the perpendicularity of the plane of the device. Just be careful of the aorta tortuosity when you retrieve the balloon. You have to be in front of the catheter. So the final result was good with a good expansion of the device, no PVL, no cardiac disturbance to the right at the bottom with no left bundle block branch, and a final good result. We retrieve the Sentinel device and then the closing of the femoral. So we check the presence of material in the Sentinel, a little bit, not so much. So we associated with 8 French angiosyle with a good result. So incidence is really important to be perpendicular to the annulus and perpendicular to the device to decide and to choose, depth implantation. The radiolucent line was here a little bit low, I think. Maybe we can be a little bit more up in the bicuspid the bicuspid valve. So we have to understand that the seal of the SAPIEN 3 is in the intercommissural space, so we have no PVL. So take-home message, CT sizing is the gold standard. No perfect method for the sizing. We have to use a combination of the 4 methods and to have a team discussion. We should minimize oversizing less than 3 or 5%. We have to consider calcium burden when we have a bicuspid aortic valve with huge calcification and a low-risk patient. His first-line treatment is surgery. The place of cerebral protection is unclear, and we are waiting for result of a randomized trial to compare TAVI and surgery in bicuspid aortic valve, and also a randomized trial to compare SAPIEN versus Evolut device in bicuspid aortic valve. So thank you.
Thank you, Walid. It was a very nice life in the box. These are very difficult patients to treat with TAVI, and the selection is key. As you mentioned, all the data that we have and we've seen in the published already are very selected patients, so be cautious when you interpret this data. So I will jump in on one of your take-home message and ask Juan, who's with CRF, designing a lot of study. Do you think, Juan, we will get a day, a real face-to-face SAVR to TAVR trial comparing these two approach for bicuspid patients, or that will be difficult as the prostheses are already FDA approved for this indication in the US at least?
Look, I think it's absolutely needed, I mean, no question. And there's some planning groups trying to actually do that. The thing is, from the company point of view, what would they do a trial when everybody's using it, you know, in multiple anatomical conditions? But one of the things that I want to make an emphasis, especially people that don't have very high volumes, is that there are 2 conditions in which you have to be particularly careful and have a lot of experience in TAVR. One is bicuspid, the other one is aortic insufficiency, because they are variations of aortic valve disease, but they are not pure aortic stenosis. And you can really make a lot of mistakes, and you can actually end up with big outcomes if you don't really have the experience of previous cases to avoid certain things. You know, he was talking about, for example, be careful with sizing. You know, you cannot be very aggressive with sizing. One thing that I would love to get your opinion on is predilatation according to the type of raphe. Because, you know, sometimes, you know, people, there is a tendency, which I completely agree with, of pre-dilating before, you know, putting the valve. But sometimes these raphes are so complex that you may end up rupturing the annulus. So this is actually one thing that experienced operators, you know, learn to see, learn to appreciate, and say, you know what, maybe in this case it's better just to put the valve in and we're done for the day. But I would actually say that if you just started a TAVR program and you have a bicuspid case, discuss it in detail with the surgeon, because as I'm going to present actually a few slides also, these patients actually have worse outcomes than a regular TAVR patient.
Walid, I have another question for you. I saw that you used Sentinel. You know that the trial was negative for this subgroup population. How, I know you're in private sector, but how you can discuss with your administrator to use these devices when you have no evidence that can back this, the use of these devices to protect the brain?
Yes, it's an expensive device. So we use it really carefully for bicuspid aortic valve patients. Indeed, it's negative. The studies are negative. And also in TAVI valve in young patients. For the payment, we have to deal with industry, and they can help us to pay this type of devices.
And Sami and Leila, how you, what is the percentage of bicuspid patients that you are treating with TAVR in your beginning experience in Tunisia?
Now, I think now we have treated 10 or 12 bicuspid valve. But when we see our listing, or large listing, now we are analyze better, and I think the incidence of bicuspid is now more than 25% of patients.
We have a little experience with TAVI in bicuspid valve. And if I think the first case of implanted TAVI is fax was bicuspid. When we started the experience of TAVI, it was the bicuspid, but I think it's about 10% of the patients who are bicuspid.
And how you follow these patients? Are the results good? How
yes,
is it performed well?
Yes, we have a good results of all the patients, all the TAVI implanted in our department. We have very good results. Probably I have a question to Walid and to all the panelists about the choice of the type of valve. Do you choose self-expandable or balloon expandable in case of bicuspids? What are the criteria to choose between? Because I see that you put balloon expandable valve in this case.
So results between the two devices seems to be comparable. We have also good results with self-expandable devices. Indeed, in terms of choice, we have to anticipate the risk of PVL, also, which may be higher with Medtronic auto-expandable devices. And also the risk of pacemaker is also a little bit huge, more important. So also the last point is the operator experiences. It's really important.
I honestly don't think we have the data. I mean, I don't think we can really say there is one device better than the other. Intuitively, you know, what people have tried to say is because self-expanding devices are, in general,
smoother.
You know, more adaptable. Maybe that's one potential advantage. But to be honest, until we have had to have comparative data, it's difficult to really say if there's an advantage of one versus the other.
I completely agree. And my only advice: use the device that you master better. You know, if you're a center doing more self-expandable, use the self-expandable platform. Otherwise, use the balloon expandable one.
What is the incidence of bicuspid in very big volume?
10%.
In my center, I'm trying to send all bicuspid to the surgery, except patients that are not good surgical candidate. I think that one surgery, have a good result with bicuspid. Two, there is what we have not discussed here, the aortopathy, because my team is very aggressive for the aorta, so at 45 millimeters, that will change the aorta. And this is the guidelines. If you have the high volume center, you can change the aorta at 45 millimeters cutoff. And let's be honest, with the TAVR, we had good result, but not perfect result. Showed with the Yoon paper, actually. When you have an intermediate, you have paravalvular leak, moderate paravalvular leak in almost 15 to 20%. And this paravalvular leak will impact the survival one day. And they are young. They are relatively young compared to tricuspid valves. So if you can operate on this patient, I will operate the patient. If I cannot, I will do the TAVR, but with talking to the patient that we can expect suboptimal results.
Dr. Slim Boudish.
Thank you, Walid, for this great presentation. So my question is, I know that you are a big fan of very high target depth implantation. You showed us. But what about bicuspid patients? They are often younger than conventional TAVI candidates, and as for lifetime management, we know that probably a coronary reaccess needs to put the valve a little bit deeper. So what is your opinion about that?
Yes, it's a good question. We can anticipate it with the SECOL method to anticipate the height of the seal of the device. Indeed, we are looking for the seal in the intercommissular space, in this case, because it's a tapered configuration. So we have to adaptate this depth implantation between anatomical consideration and, you're right, between lifetime management with young patients. Yes.
Thank you. We have to move on, please. Slim Boudish, you'll make the next talk, and the talk is how to manage coronary disease in TAVI patients.
So thank you very much. Good morning, ladies and gentlemen. I'm very honored to be associated to this session, joint between STCCCV and TCT, and dedicated to TAVI patients. So the question asked to me is how to manage coronary artery disease in TAVI patient. No conflict of interest, and the question is really very important because coronary artery disease is present in about a half of patients scheduled for TAVI. So this is an important percentage, and coronary artery disease is frequently found as a bystander. Exceptions are here as acute coronary syndrome, severe angina, left main severe disease that may be a situation that mandate immediate PCI, such as the case of this patient. So as a bystander, coronary artery disease raises many questions, and I will try to approach it by three successive questions. The first one is how to evaluate coronary artery disease in patients with severe aortic stenosis. The second question will be how to treat significant coronary artery disease in TAVI candidates. And the third question will be how to preserve coronary artery reaccess after TAVI. So these are the main three objectives of my talk. The first one will be how to evaluate. So coronary artery disease will be evaluated in TAVI patient by invasive coronary angiography. This is really the current standard of care. It is supported by current practice guidelines. Since we are talking about elderly patients with high coronary artery disease probability with significant burden of calcium, and invasive approach will allow to immediate physiological or imaging assessment, and it will allow also potential proceeding to directly PCI. So you see the case of this patient we performed in TAVI. So you see the calcium burden. You anticipate the difficulty of the CT scan to really assess, or non-invasive approach to really assess this coronary artery disease. So what about physiologic assessment? I think that data are still lacking, and we need more validating information, because FFR and EFR may be impacted by the hemodynamic and anatomic changes with the severe aortic stenosis, and measurements may be highly impacted. We have some data coming, such as this large registry from Verona, and we see that FFR did not change significantly before and after TAVI in most cases of patients. And negative FFR, as you can see here, increased after TAVI, and positive FFR decreased after TAVI. a small amount of patients crossed the cutoff of 0.8. It was less than 6% of patients, and that impacted certainly the revascularization strategy in this registry. So there is a place for invasive assessment, but it needs more validation. CT can be an alternative because it can be coupled with the systematic MS-CT before TAVI, but CT faces and is tackled by the calcification and the highly probability of coronary artery disease in such old patients. It can be proposed for younger, because we are targeting younger patients now for TAVI, when coupled to pre-TAVI CT. So for the second objective, it will be how to treat coronary artery disease concomitant to present in patients scheduled for TAVI. And now we have some data. We have randomized data. You saw this trial coming from Elvin Keddy, presented in the last EuroPCR 24. This is randomized data. This is a small-sized trial, but showing that percutaneous approach did better than surgical approach, and it was a 1-year follow-up, and as you can see, percutaneous approach reduced MACE at 1 year here when compared to surgery, and it reduced mortality at 1 year, as you can see here, significantly, and this mortality reduction was not in relation with procedural deaths. So this study was stopped by the ethics committee, and we have some corroborating data coming from the Spanish registry. This is a retrospective registry of more than 1,000 patients, and you can see that, like the TCW trial, percutaneous approach did better on major outcomes than surgical approach at 1 year. So less mortality, less stroke in the patient undergoing TAVI plus PCI than patient undergoing SAVR plus CABG. And we know that prognostic of surgery when we are performing CABG concomitantly to valve replacement is associated with a high mortality at 1 year. So what supports PCI also is the recent publication of the Notion 3. It is a Scandinavian multi-center trial recently presented in the USC Congress. And you see that PCI should be proposed for patients with severe stenotic coronary artery disease. What means severe coronary stenotic coronary artery disease? It is an FFR guided or angio more than 90% diameter of stenosis. So PCI did better than medical treatment in this setting of TAVI patient regarding outcomes of MI here, MI, and target vessel revascularization, but did not improve mortality. So it is really an up-to-date trial targeting low to medium risk patient, and you see the reduction of myocardial infarction and the need of urgent revascularization in the PCI arm, but without reduction of the major criterion of death. It was associated with a little excess of bleeding because PCI performance needs DAPT, and DAPT is associated in these fragile patients with bleedings. So the trial was positive, especially for lesion more than 90% of diameter stenosis in favor of PCI versus medical therapy. So the other question, so surgery no, PCI okay for severe stenotic coronary artery disease. And the other question is the timing of PCI. Often the PCI is complex. We are facing very calcified lesion, very long lesion that may need preparation, that may need guide extensions, etc., like you see in this case for Pretavi PCI. So timing can be before in complex situation, or also we have some data supporting performing PCI after, so deferring PCI to after TAVI. And this deferring supporting data are coming from the activation trial. You see here that with, among patients with minimal angina, we can defer PCI without risk on mortality or major outcomes. And we are here reducing the bleeding outcomes, the safety outcomes when deferring PCI after the TAVI. Other data supporting deferring the PCI for after TAVI are coming from the multinational US, European, and Japanese revascularization TAVI registry. It is a big registry of more than 1,600 patients that were compared if having PCI before, concomitantly, or after TAVI. So 3 arms, statistically adjusted, and we see that performing PCI after TAVI was associated with less deaths and less stroke. So deferring PCI was with a positive impact on death and stroke when we perform this revascularization after TAVI and even after landmark analysis for events after 30 days, so events not related to procedures. So the third objective will be how to preserve coronary access after TAVI. This is the third question. It is an important one. So why to preserve coronary access? Because we will need this coronary access after TAVI in about 60% of patients at 5 years. And most of these patients will come back to cath lab because of an acute coronary syndrome. So we need an effective and rapid access to coronaries, especially that we are treating younger and younger patients where coronary artery disease can evolve and patients may face acute coronary syndromes. So this is the lifetime management of patients undergoing TAVI, and we must take into account the possibility of future need to coronary access. So this coronary access is impacted by many factors. The first one is the stent frame height. So as you can see, the balloon expandable one is the champion here because of the stent height, the lowest stent height. The second factor is commissural post height is here. As you compare self-expandable valves, they don't have the same commissural post height, and the evolute valve have one of the highest one in this case. The third factor, you see the strat wide. So also the Medtronic valve has the smallest strat wide in this case, and may provoke a real challenge to coronary access after TAVI. Sure that anatomical criteria are important, such as coronary heights, Valsalva width, sinotubular junction width and height. These are anatomical considerations. Implant depth, I was asking to Walid this question. So if we need reaccess, we can put the valve a little bit deeper, like here, to have a better access to coronaries after. So coronary access may really be challenging, especially when we are coming back for TAVI in TAVI or TAVI in SAVR. And commissural alignment here is the best way with the self-expandable valve particularly to preserve the coronary access. So we need to perform commissural alignment. You see, when we perform commissural alignment, we have an easy access to coronary after TAVI. So 3 steps. We must have the cusp overlap here view. We must assess it by CT. Then we must know where is the commissure of our valve, like the commissure here from, for the valve from Medtronic. And we need...
Can you please go to your conclusion slide?
Yes.
We are
we
a
need
little bit behind.
to perform this commissural alignment to preserve really the coronary access. So these are technological improvement in Medtronic valve to ensure that commissural alignment and coronary access. Tips and tricks to reassess the coronaries are available. We need to shorten DAPT or antithrombotic therapy after PCI to tackle the bleeding issues. Ongoing trials are here, especially like FAME trial with Faith TAVI, assessing FFR in the context of TAVI. And my take-home message will be evaluation will be made by invasive coronary artery angiography. Invasive physiology needs a more validation. Management will be sure by PCI over surgery of coronary artery disease. It should be performed before TAVI when stenotic are more than 90% on proximal artery disease and can be deferred in the other cases. And we should preserve future access to coronary after TAVI. Thank you very much.
Thank you, Sim, for this nice literature overview. So we, for the sake of time, will move directly to the lab in the box. Please keep it in less than 20 minutes to have a nice discussion at the end of the session. So the next speaker will be Tarak Alouz from Hadi Shaker Hospital. He's presenting a lab in the box, a case of small annulus treated with TAVI.
Thank you, Walid. Good morning, everyone. I would like to thank, first of all, all the Tunisian Society of Cardiology, or the board of Tunisian Society of Cardiology and Cardiovascular Surgery for inviting me to speak about the management of TAVI patient with aortic small annulus. It will be based on Life in the Box that we did last Monday with my colleagues, Dr. Salma Shafuddin and Dr. Elabit. It's a great honor for me. So I don't have any conflict of interest with this case and this presentation. It is about a 77-year-old woman in overweight with symptomatic aortic stenosis in class 3 of dyspnea. She had a medical history of hypertension, hypothyroidism, and atrial fibrillation with moderate chronic kidney disease. She had also a history of pulmonary embolism in 2015. So this is the echocardiography that showed severe aortic stenosis with Vmax at 5 meters per second, the mean gradient at 45 millimeters of mercury, and the calculated aortic valve area at 0.45 centimeters square with a good ejection fraction, as you can see. The ECG showed atrial fibrillation rhythm with normal duration of QRS at 95 milliseconds, and the laboratory investigation confirmed this renal failure with a GFR at 46 millimeters per minute, and the coronary angiogram was normal before TAVI. So here you show a detailed CT scan analysis, and briefly the CT scan showed a tricuspid valve, in this case, with a small aortic annulus showing a perimeter at 68 millimeters, the area at 347 millimeters, and the perimeter derived by diameter at 21.6 millimeters. The sinus of Valsalva in this case was large, was favorable, with ranged between 27 and 30 millimeter with a good height. So the distance between coronary ostia and the annulus was favorable on the right side at 40 millimeter and also on the left side at 11 millimeter. As you know, with CT scan, you can assess our working views, 3-cast view and cusp overlap view, and currently the cusp overlap view is recommended to implant the self-expandable valve. So at the lower part of the body, the transfemoral axis is favorable with MLD in the right femoral artery at 6.8 millimeter, and as you see, the iliofemoral axis is not tortuous and is not calcified. So after this indication, the calculated surgical mortality score was at 5% with Euroscore 2 and nearly 4% with the STS score, and with suitable anatomy for transfemoral TAVI, like transfemoral axis is good, tricuspid valve, adequate coronary height, and a good sinus of Valsalva width. So the heart team in our center have chosen the transfemoral TAVI, and I let you follow our life in the box.
Department Head of Cardiology of University Hedi Sheikh Hospital of Sfax. In the name of our team, Dr. Taraq Allouz, Dr. Salma Sharfuddin, Dr. Suad Malek, Dr. Amin Al-Bahloul, and our anesthesiologist, Dr. Allouz, we would like to thank the Tunisian Society of Cardiology for letting us sharing with you TAVI case of 77-year-old female with a small annulus that will be treated with Evolute Pro Plus 26, and as a sitting, the patient is under conscious sedation with deep local anesthesia. We plan to perform the case through right femoral artery as a principal axis and left radial secondary axis. And as a team, we pace over the wire, and we will deploy the valve following the optimized Pro technique. So before inviting my colleagues to start securing the principal axis and starting the procedure, I'd like to thank our friend and colleague, Professor Walid Ben Ali, for his support.
So thank you, Professor Abid. I'm Salma Sharfuddin. I'm here with my colleague, Dr. Taraq Allouz, and we will start this procedure. We, you see, secure the primary axis, femoral axis, with the echo-guided puncture, and then we will do pre-closing with the standard 2 proglide.
Visualizing the femoral artery, and after local anesthesia, we puncture under echo the anterior face of the artery.
Okay.
Puncture is down.
So we will check here the femoral axis.
So we are putting our pre-close with 2 proglides.
First one.
As is recommended in our center. Yes, the first one at
Dr. Taraq Allouz, and we will start this procedure. We, you see, secure the primary axis, femoral axis, with the echo-guided puncture, and then we will do pre-closing with the standard 2 proglide.
Visualizing the femoral artery, and after local anesthesia, we puncture under echo the anterior face of the artery.
Okay.
Puncture is down.
So we will check here the femoral axis.
So we are putting our pre-close with 2 proglides.
First one.
As is recommended in our center. Yes, the first one at 10 o'clock.
So we have here the second proglide.
So you can put heparin, 8,000 unit. Vas-y. That's a very nice 3-cast view. So now you will cross the valve with a straight wire and on-plats catheter.
So we have here the Confida wire in the LV.
According to CT scan analysis, our valve isn't now very calcified. So we plan to do a direct valve implantation without plate dilatation.
So now we will check the valve to assess the crimping.
So our valve is well crimped. Okay. Donc you must introduce the sheet carefully.
So here we will introduce the delivery system, and we have the flash port at 3. So here we turn at 12 to have the heart marker at the
On the outer curve of the aorta.
aorta, yes, and to ensure
As you see,
the commissural alignment.
yes, and here we'll test our pace on the wire. Okay, we'll test at 110. Now we will move to the cost overview projection.
So here we will check again the heart marker.
Donc we'll do test here, a little bit deep. We push on the wire to yes, to retrieve a little bit our valve. Donc we'll do test. Here is good. The picture isn't in the bottom. Yes.
The valve seems to be at the good
At a good position.
Exactly. 160. Go. Quickly. Stop. Stop here. Stop pacing. There are any block.
Okay, perfect. So here we will do an aortogram to check the depth of the valve on the left side, and also the coronary permeability, and to check the perfusion of the coronary artery.
Yes. Very good. Here you will retrieve the wire.
To centralize the nose.
Try the nose cone and LUT.
We will go slowly
to the end of deployment.
the end of deployment.
Okay. Yes.
Very nice deployment.
Very nice. Okay. Our valve is deployed. Push the wire. Push. Okay, perfect. Here we check hemodynamic gradient. So in our case,
Okay.
as you see, we don't have any gradient between LV and aorta.
Okay.
So the importance of this valve with supraannular platform. Inject. Nice result.
Depth, and we have
Nice depth, and don't have.
left main,
Yes.
good perfusion.
We'll move on the cusp overview. Inject.
A good position is
Yes.
Yes.
The final depth is 2-3 millimeter nearly. Yes.
and we have a good coronary perfusion.
Coronary perfusion, and you don't have PVL. And now we are going to close the two pug lights to ensure our vascular time. We are descending our pigtail catheter through the radial artery to descending aorta to perform a final injection in the iliofemoral axis and check for the absence of vascular complication related to the axis.
So we have the final injection
Iliofemoral
of
axis.
iliofemoral axis, and we have no vascular complication.
Okay.
So
Thank you very much.
Thank you very much for your attention.
Thank you. Thank you. So the echocardiography 1 day post-TAVI, 3 days ago, showed a good ejection fraction at 60% with no PVL, no paravalvular leak. The mean gradient is good, donc at 3 mm of mercury, and the effective orifice area at 2 cm square, and the high Doppler velocity index at 0.79. The ECG showed atrial fibrillation with minor prolongation of QRS duration rated to incomplete LVB at 116 milliseconds, and the renal function was stable, and the patient was early discharged to home after 2 days from TAVI. So after this case, many points deserve further discussion, like vascular access and the importance to use echo-guided puncture to avoid vascular complication. The optimized approach with temporary pacing over the wire and rapid pacing up to 160 between annular contact to point to non-rupture of the valve. But the main question in this case remain that which valve should be chosen to improve outcome after TAVI in patient with small annulus. So in this area, the definition at today isn't clear, and no clear consensus has been established regarding the cutoff value of defining small aortic annulus. Regarding to surgery data, small annulus is defined by diameter under 23 millimeter measured in echocardiography, but in the field of CT scan, the definition was shifted to annulus area, and the small annulus is defined by area under 400 to 430 millimeter. So the reported incidence of small annulus isn't rare, up to 30% in a control study, and the great majority, the big message, the great majority of patients are women, up to 80 to 90%. And a recent publication of German registry with over 8,000 patient TAVI, the most significant clinical implication is the prosthesis patient mismatch, the severe PPM, which is common, very common, affecting 38% for all patients. And the self-expandable valve maybe reduce this poor outcome, and the post-dilatation after TAVI may be also reduce and decrease this incidence of PPM. So in this purpose, the SMART trial was designed, and yesterday we attended to complete presentation with my friend Dr. Walid Bilali. But briefly today, this study it's a randomized trial that compared two strategies, two valves, self-expandable valve versus a balloon expandable valve with SAPIEN 3 to treat symptomatic aortic stenosis patient with small aortic annulus defined in this study by annulus, areas of annulus under 30 millimeter square. In this study, the prevalence of female sex at up 86%, and two complementary endpoints. The first was clinical outcome for non-inferiority, and the second complementary endpoint was biprotective valve dysfunction at 1 year for superiority. So after 1 year of follow-up, the non-inferiority of self-expandable valve was confirmed with the first clinical endpoint, and there were no differences between two valves regarding all-cause mortality, stroke, and hospitalization. However, the second complementary endpoint is in favor of self-expandable valve with a big reduced of the incidence of BVD, of biprotective valve dysfunction, by 32%, and it was driven principally by two outcomes. First of all, the incidence of SVD, it's reduced by self-expandable valve, and the incidence of severe PPM and more than moderate aortic regurgitation is reduced significantly with self-expandable valve. And if you look at other hemodynamic outcomes, you see that self-expandable valve allows superior hemodynamic valve performance at 1 year with lower mean gradient and higher Doppler velocity, as you find in our patient. So this finding is very important, because if you look at surgery data with biprotective valve, you find that there are a strong correlation between PPM with biprotective valve surgery and long-term mortality. So may take home message that you need to apply minimalist TAVI with pacing over every wire, cost overlap implantation view to accurate the implantation depth of self-expandable valve. And the small annulus is not rare, 30% in a study, and the great majority of these patients are women. The superiority of supraannular self-expandable valve is demonstrated to decrease biprotective valve dysfunction, particularly hemodynamic SVD and severe PPM, that may have impact in durability.
So thank you for this nice case. We will move directly to the next talk with Dr. Juan Granada. We'll discuss durability. Durability is one of the crucial thing about TAVR, and as a surgeon, unfortunately, is one of the arguments to face the expansion of TAVR. So Juan,
yeah, thank you.
Please bring us to the future also, with the future horizon of the TAVR.
Thank you, Walid. And I think this was a terrific session, because presented perhaps the areas of more intense investigation in TAVR today. So I'm going to try to summarize a lot of the data. This is very different than yesterday when we discussed mitral and tricuspid, because TAVR is a very mature and advanced field. So we are at a completely different level. So one of the things that I would say with a high level of certainty is that right now we can say that TAVR established already its performance against surgery, and there are actually few areas in our field that can really claim that went through a very extensive process of validation through different patient subsets to be able to demonstrate the non-inferiority in terms of performance in compared to surgery. You see all the trials listed here that you know very well, but this slide actually shows, how comprehensive the process of evaluation of TAVR has been, starting with inoperable patients and going down to low risk, patients. Also this year, a seminal publication by this German group essentially confirmed in an independent way in a patient-level analysis that TAVR in the great majority of patients is not inferior than surgery, and this is actually something that is a very, very important message. Let's focus a little bit on the low-risk patients, because this is a group that requires a very particular attention, and we can say that in two different type of valve designs, shown here, at 30 days, the percentage of death or disabling stroke at 30 days is very small, less than 1%, which is a big advantage, against surgery. And actually, we can really say that at least with this intermediate follow-up data, these are very encouraging results in a population that is perhaps, the biggest population we can address. Data for low-risk population right now goes up to 5 years, and the data remains, very stable in terms of comparison to surgery, and this is highly encouraging. A piece of information that was presented at TCT that I really think is very encouraging, because this is one of the big questions that needed to be answered, is if you base your decisions on guidelines, you really want to treat patients who are completely symptomatic. And the early TAVR trial that was presented at TCT, wanted to answer this question. If the patient doesn't have symptoms, but it still has hemodynamic aortic stenosis, would these patients do better with TAVR versus conservative therapy? You see here in the conservative therapy group, at 5 years, the composite endpoint of death, stroke, and unplanned rehospitalization was 50%, and in the TAVR group was 35%, which essentially showed a significant benefit for preemptively treating patients, even they don't actually have symptoms. Now, one thing that I have to clarify, these patients were truly asymptomatic, and these patients were evaluated by echo and stress test. Which is important and interesting to see is that the endpoint is driven primarily by unplanned cardiovascular hospitalization. No significant impact on death, no significant impact on a stroke, but pretty much the message is if you have a patient already with very severe aortic stenosis and the patient doesn't have symptoms, the conversion to any type of aortic valve intervention is going to happen anyways in 5 years. So I really think this is going to be a guideline changer type of a trial that essentially shows that really waiting for somebody to get a stroke or syncope or become symptomatic doesn't make a lot of sense. So one of the biggest changes that actually has happening in the use of TAVR, and this is data coming from the US for over 100,000 patients underwent isolated valve replacement, is that now people are more aggressive in treating younger patients. And of the entire population cohort, this is a Medicare, Medicaid cohort, at least 12% of the patients are younger than 65 years of age. And you see the percentage of patients undergoing TAVR in less than 65 years is increasing, the number of surgeries decreasing, but just to make it clear, these patients are typically very sick. with chronic kidney disease, history of bypass surgery, and non-bicuspid aortic intervention. But this is when I put a stop and I say, guys, I think it's too early to start putting Christmas decorations and start celebrating because we don't have the data yet. This is the current timeline data from randomized trials of TAVR versus SAVR. And you see PARTNER 2 and SORTAVI that essentially got intermediate risk patients. We have essentially data that is going to be released 10 years in 25 or 26. The same thing for the low-risk trial. So we don't have 10-year data yet. I don't really think that many things are going to change, but I'm a person that actually believes that unless the data is properly presented and disclosed, I don't think we can really say we have a 10-year durability data in intermediate and low-risk population. We're getting there, but this is a word of caution in which I believe we need to be very conservative. Why this is the problem when you go younger? When you go younger in a younger population, you're going to find more complex disease, especially bicuspid aortic stenosis. And bicuspid aortic stenosis is a completely different animal. Bicuspid aortic stenosis, as we saw, is something that you need to be very careful because the technique, devices were not designed for this type of pathology, and the outcomes are different. As an example, this is the only trial that is being presented today with 10-year follow-up. If you see this figure here on the left, when the pathology was a tricuspid pathology, the outcomes were similar between surgery and TAVR. When you actually do the analysis, again, in small numbers between bicuspids, you really see that surgery excelled over TAVR. Again, it's just a word of caution to be smart and actually use the devices the proper way. As we discussed throughout this session, TAVR innovation essentially is moving into areas that need a lot of help. Bicuspid aortic stenosis, a small annuli, and aortic regurgitation. And we started to see data. This data was presented at TCT that Stefan was talking about with the Trilogy TAVR, which is perhaps the most advanced aortic insufficiency device. And we already have 2-year data, non-randomized. And as we move forward, we're going to start getting data with these innovative devices. This is one technology worthwhile presented because it shows the evolution of the frames. This uses a brand new material that is called rhenium and actually allows the frame to be very thin. Therefore, you can actually treat a small annuli at the same time get actually bigger EOAs. And this is a system that is already in first-in-human studies. One of the big problems that we spoke about earlier is that a lot of patients are undertreated because they don't have symptoms or they don't have access to care. And there is a lot of questions about upstream therapy. Somebody was asking yesterday, how do we screen more patients? How do we get more patients to be taken to the cath lab? And this is an area in which I know you're interested in, which is artificial intelligence. And there is a lot of work on trying to create predictor models to be able to really bring patients quicker to the cath lab. So innovation in TAVR is actually shifting. And the big shift is do it once, do it right. Let's avoid bringing the patient back to the cath lab. And you see that we're moving from octogenarians with tri-leaflet disease and low physical activity to actually more complex patients, younger patients with more bicuspid disease and more activity. That is why, as we discussed in the previous talk, it's very important device selection, technique selection, and aortic coronary access. And that's why new designs of new frames will be more friendly to actually allow access in the patients. And as you saw at TCT as well, going to be a lot of devices trying to optimize leaflet splitting to increase the number of patients that we can treat. So just to wrap this up, one thing that is important at the end of the day, when we have actually all this data, the field will go into one single question, which is the most durable device. And this is very difficult, questions to answer because the definitions are different between devices. But it's fair to say that up to 5 to 8 years, the numbers are looking very good for severe, valve dysfunction and bioprosthetic valve failure. And I am sure it will continue to be like this. But the future of the field relies not on the frame, but actually on the leaflets. There is a lot of work on bioprosthetic, artificial leaflets, polymeric leaflets, and actually advanced generation leaflets to be able to not only achieve the durability that we want, but decrease the need for anticoagulation. So this is my closing slide. Alain was a very good friend of CRF. We enjoyed it greatly, and we owed him, a lot of what happened in this field. He was always a person that was always looking for, okay, what is actually now? And I'm going to close to, my mentor, a good friend, Marty Leon, always says, there is still a lot to do. So this is a field that will continue to evolve, will continue to grow, and will continue to bring fascinating solutions, to treat these patients that are in greater need. Thank you very much for your attention.
For this great talk. I think for the sake of time, we'll close the session. We got an impressive session. I'm really happy to be with my friends and with my Tunisian colleague here to discuss TAVR. This is the future. We saw that during two really nice live cases for treating difficult anatomy, small annuli, and bicuspid aortic valve. We discussed with Juan today how we can expand indication and what the future will be made, and how we can push the boundary, expanding indication, but also improving the technology. We saw with Stefan that we can treat aortic regurgitation, and data are coming, and the guidelines will change for sure in the next year. So thank you very much to be here with us, and hope we'll be with you the next year.